When and how do such symptoms arise? Often associated with trauma or highly stressful situation. Dissociative disorders are frequently defensive mechanisms that become symptomatic over time. So when does healthy use of defense mechanisms become unhealthy? When behaviors develop into maladaptive, turning into pathology, the ego is the balance of the mind and self. Probably the easiest way to explain this is Jessie was in her 40s. That just seems weird. Anyway, a married woman with a youth and young adult as a sex slave. When her girls reached the age when her life changed, her anxiety pathologically changed to dissociative with the use of alters. After years of living in this state, a person began to integrate her alters, learning that this was her way to keep her daughter safe by keeping her enemies closer. A short story that was years in the making. Part of that the way it was worded didn't make sense to me, but that's okay. Disorders. Dissociative identity disorder. Once known as multiple personality, two or more distinct personalities, a difficult disorder to treat and have in a group. Dissociative amnesia, localized and generalized. Depersonalization/derealization disorder. The person feels detached from their entire being. Be careful of this one with DID. Somatic disorders. Yeah. We need to review these disorders because they come up frequently in medical settings when symptoms are unexplainable. A distinct characterization is not necessarily the somatic symptom, but the way they present and interpret them. To get a true picture, one must incorporate affect, cognition, and behavioral components to accurately assess the clinical picture. Elimination of some somatoform disorders. Sorry, some of these words I have a hard time pronouncing. Disorders. Somatic symptom disorder. The person has multiple symptoms which are a disruptive to daily life, may or may not be associated with a medical diagnosis, illness, anxiety disorder, preoccupation with having or acquiring a serious illness. This is also your quote-unquote hypochondriacs, conversion disorder, one or more of various types, motor, sensory, abnormal generalization of limb sensation, often is a go-to disorder for MDs when it is not explained by medicine. Fictitious disorder, falsification of medical or psychological symptoms. So this week with dissociative disorders and somatic disorders, you are required to conduct a thorough assessment, often involving significant others and family members. There is nothing straightforward with these such disorders. Dissociative disorders tend to be as a result of traumatic experiences. Somatic disorders tend to be the result of significant distress and impairment, whom show up in primary care more than the average person. Often seen as medical related, the mind-body connection. Malingering in a V code in the DSM-5, it has its own disorder in the DSM-4. Feeding and eating disorders. Generalization. Persistent disturbance in eating results in an altered or absorption food and significantly impairs physical health and psychological functioning. Pica, rumination, avoidance/restrictive food intake, anorexia nervosa, bulimia nervosa, and binge eating. Mutually exclusive, so during a single episode, only one of these diagnoses can be assigned. Because the disorders vary greatly, therefore requiring a specific clinical course, outcome, and treatment needs. So why is obesity left out? Often results in a long-term energy intake relative to energy expenditure. There's a range of explanations: genetic, psychological, behavioral, and environmental factors, which is why obesity is left out. Disorders that once considered relevant to childhood, pica, the consumption of non-food and non-nutritive substance, has been expanded to to adulthood. Rumination often occurs in infants and intellectual disabled individuals. This is repeated regurgitation of food, a process of rechewed food, re-swallowed, or spit out food. Avoidant restrictive food intake replaces the feeding of infancy or early childhood. Anorexia nervosa, remember to think in terms of two things. Restricting type, binge eating / purging type, or severity is based on the BMI range. Crossover between disorders is not uncommon. There are 3 features: persistent energy intake restrictions, intense fear of gaining weight, and a disturbance in self-perceived weight or shape. There are certain medical markers to support a diagnosis, becoming very common in young men and boys. Bulimia nervosa, characteristics of binge eating, eating at the specific time and amount of food that is significantly larger than needed, and a sense of lack of control over eating. Such patterns should occur at least once for 3 months. Severity is marked by number of episodes, most common in adolescents and young adults. Binge eating disorder follows suit with bulimia nervosa with additional 3 of the following: eating much more rapidly than normal, eating until feeling uncomfortably full, eating large amounts of food when not feeling physically hungry, eating alone because the feeling of feeling embarrassed by how much one is eating. Severity scale is similar as well. And these are a couple binge eating things that they said that we could go to. So what about compulsive eating, eating for emotional cues, and holiday eating? Or just some thoughts that they had.